Good afternoon. Thank you so much for joining us in person and on Zoom. I am Alexa Smith, and I'm the Educational Exchange and Event Program Manager with the Office of International Programs, and this is Foundations of Global Health in conjunction with the International Orthopedic Trauma Collaborative. Just a little bit about Foundations of Global Health. Global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. And that comes from the Consortium of Universities for Global Health. Global health is a varied and rich discipline to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world, this ongoing programming through the Office of International Programs is designed to feature those in our KUMC community engaged in the field of global health. KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. Presenters will share their personal journeys, educational backgrounds, mentors, books and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and even the heartbreaks. The series is meant to provide a platform for both presenters and participants to participate in conversations while developing foundational knowledge and exploring best practices for engagement in the discipline of global health. And we're back next week on May 6th with Faith in Medicine, How to Live Yours Out While Respecting Others. And now I will turn it over to our next speaker.
Good afternoon, everyone. My name is Dr. Bezagrov. I am an orthopedic surgeon and doing a fellowship in KU in trauma and as well as in hip and knee arthroplasty surgery. I came from St. Paul Hospital, Millennium Medical College. It is a teaching institution, and me, before I came here, I used to be a program director in an orthopedic and trauma residency program in Abbott Hospital. So I'm going to present you a snapshot of orthopedic trauma in Ethiopia, which is more or less quite similar when I was back in home. And this is the building of Abbott Hospital, which is an affiliate of St. Paul Hospital, Millennium Medical College. IOTC stands for an abbreviation for Addis Ababa Burn Emergency and Trauma Center. So this used to be this building used to be a hotel, which is like St. Paul rented this building and changed it to this Abbott Hospital. So this is something. This is when this picture was taken when the hospital was inaugurated in 2015. But this is what it looked like just before I came here. And it is like, as you can see from the picture, there are a lot of, it's congested, like parks, like cars are parked in front of the emergency. This is the emergency main gate to the hospital, emergency main gate to the hospital. As you can see, there's an ambulance just parked in front of the emergency hospital, and there are a lot of cars parked around because we don't have this parking lot. So you can imagine how an ambulance can come and park here and put the patient for the emergency and critical care here. It's very difficult. This is the outside, and this hospital is blocked by like a more than a 2-meter height bricks of building with, this is a door which is a 4-meter and approximately a 4-meter wide door with a door gate here, and there are also you guys have like in the inside the hospital, like we can take a tea or coffee breaks and something like that. But these are on the side. There are little shops which sell fruits and stuff, food for the patients as well as for the patient visitors, and which is very congested here. And there are times in the compound. There are times where road traffic accidents really happened when like cars trying to park around the hospital. So it's not unusual to find a trauma even inside the hospital, road traffic accident. So what are the common things that causes orthopedic trauma in Ethiopia? So we have road traffic accidents, which are the main ones. We have falls, and as everyone knows, we are right now in kind of a civil war in different parts of Ethiopia. And we have also occupational injuries and sport injuries. Road traffic accidents in 2020, which was studied by Malina. I took this from a local from the country's journal. It's reached 31.5% trauma cases are usually by road traffic accidents, and I try to look at other studies which more or less comparable to this figure, and around 74% are young males. In Ethiopian population, most of us are like young population. 18 to 34, a working force is usually commonly injured by these road traffic injuries, with most of the time with a fractures like 70%, and around 42 to 50% lower extremity trauma. This 42% is just for like femur tibia and something in the lower extremity, but when included the pelvis, it's reached around 50%, and other studies become like 60%, which is more or less comparable in other local studies too. And we have 14.1 mortality following traumas, and most of them are, young male. Usually in Ethiopia, males are the breadwinners in the family. So males are, as you can see, most of the time injured in road traffic injuries. The other journal, which is one of my teachers who was involved in this study. He's a pelvic and acetabulum surgeon. They studied in these traumas and orthopedic injuries in Addis Ababa. It's reached. They found out 51% was from fall down accidents, and sometimes there are ups and downs, like because we are in developing countries. We have like constructions, buildings, road constructions, dam constructions. So, but these environments are unsafe, and most of the time people fall from these buildings and constructions. And we had as high as 51% at times where there are fall down injuries. And being from this, we have also 66% involved with the lower extremity, which is comparable to the previous study that I showed you, and femur being most of the time affected bone. And when I say long bone fractures, femur, these are the reasons that in my institution, in St. Paul Hospital, that orthopedic and trauma residency program was started, because there is a company in the US which helps us in treating long bone fractures by sending instruments, like, which is called a sign nail. We use that nail, which is you don't pretty need these fancy, I couldn't say fancy, but like a C-arm for those to use in the long bone fractures. And these long bone fractures are the reason, because we have so many of them. One of the reasons to open orthopedic residency program in my hospital. Uh, so, having saying uh, this Abbott Hospital, we it was like established like I said in 2015, and earlier that when it was opened, we in orthopedic trauma we serve around 700 patients, and per month, like both inpatient and emergency and outpatient, in general, around 700 patients were treated every month. And just before I came, around 720 something, it was the average number that we serve per month. And around 400 cases are emergency, both operation and non-operative managements were given for around 400 patients each month. and we used to operate 120 patients every month in elective basis, major surgeries. So, having saying this, this is just we have this a group chat called where our residents present their elective cases. So we have groups, group one and group two. Group one is usually trauma and pediatrics groups, and uh, group two is trauma and also sports surgeries. And so they have 2 days of one group have 2 days of surgical operating theater schedule and 2 days of uh, clinics. And the other group is the same, like group one traumas and pediatrics. They have 2 days of surgeries of the week and 2 days of clinics. And Dr. Solomon, he used to operate on Fridays, on teaching days. So basically, we operate elective cases for 5 days of the week, and we have emergency every day. But my remind you that we operate 120 cases when the hospital initially was opened. And now, just one group for a week, we scheduled for one group 2 operating days, 6 cases, and we operated 5 cases. And this is randomly taken from April month, uh, our residents chatting group. So one was also 5 operated, one canceled. And the first case is like he was injured by road traffic accident, pedestrian, 23 days back. Intertrop fracture, he was operated after 23 days. This was his fracture, operated nicely with KFN. A second case, 22, young again, a fall down accident from 2 meter height, 8 days. Intertroch fracture, he was operated after 8 days. Imagine this case, they come here in KU, and when they come to the KU, how they get the treatment. You all, if you have the medical students and the surgeons here, you know how they get their treatments. But 20 days for this guy and 8 days for this guy uh, operated. So we have the surgeons. We operated on him. Uh, Another case, female, 34, still young. She has a fall down accident from a fourth floor 7 months back. She was in another facility. She has been on she was being treated there for like probably on inpatient and outpatient clinics, and she was referred to us in December 2024. In December 2024, and after that, at that time, after 8 weeks, she was treated at first stage of muscular. This is where the orthopedics came. They did an external fixation correction from which she brought from the first hospital from Munich, and XVs was corrected, and first stage muscular technique was done 8 weeks back. Then after 8 weeks, again she went to the uh, to the OR, and second stage musculate, which is like taking the cement out and probably applied a bone graft there, and they corrected the external fixator again. Um, yeah, another patient, a 16 years old adolescent, road traffic accident, 7 weeks, right open distal tibiofibular fracture. Uh, he was not treated with a granulated wound, and then he came like um, uh, after 7 weeks, when he came to our hospital, we did external fixator, and they also did, because he has already a granulated wound, debridement and split thickness skin graft after 7 weeks of the trauma. 59 years old male guy, he was pushed by an ox 3 months. Just see how when they are have the injury and when they are, when will be they have this operative management after 3 months. He has a PCL avulsion injury and he has been treated. But he had 3 months injury and after 3 months. Um, they canceled the case, 65 female fall down injury, 11 days, right closed femoral shaft fracture. She has a newly diagnosed hypertension, but she was canceled because there is lack of OR time. So if you see the cases, months, weeks are taken before they go to the operating theater. So these cases, as surgeon, they are difficult to operate. They will take time in the operation theater. So sometimes you'll be shortage of time to operate on the elective cases. So there are times which are canceled. Just see simple femur shaft fracture, which probably take a 30-minute surgery. Uh, and if you ask me why are the reasons, we have a lot of reasons like difficulties in treating patients because we are in becoming in shortage of everything, like in shortage of implants, in shortage of machineries which sterilize the medical equipment. And so the shortages are tremendous in my hospital, and even the infrastructure doesn't help you because we only have one OR, and we have surgeons and they share this OR like I don't know. Um, we are like 22 now surgeons, but we have one OR. So, one can operate for 1 week and the other can operate for the other. So, if you ask me what will be the fate of this patient, she's going to probably to wait for that surgeon to have a scheduler for like a week after. So she's going to be operated after probably a week or two when the surgeon who admitted her had a chance for operating theater. So probably a month. I don't know. And always the complication would follow following fracture like DVT, bed sore and stuff, pneumonia, you name it. Every complication that follows following a fracture, if non treated, she will probably have it. So another study, which is this guy is an emergency physician. He is also one of my colleagues in my hospital. I think he did this study in 2015 when he was like studying for emergency medicine residency program. He studied it in one of the other big hospital in Ethiopia, Blackline, and he found out average hospital stay for a patient, for orthopedic patient, is around 7.12 days, which is up to 61. There are patients who stayed for 61 days for the treatment. So we have shortage of orthopedic instruments and implants. We have lack of infrastructure. So I try to bring what my hospital looks like. And because of this, we have like our facility, our tables, sterilizing machines. We have lack of infrastructure. So this is our day-to-day activities in my country. That is one of the biggest hospitals. So that is the capacity that we can do. Imagine the other hospitals, like which is like, I mean, it's very difficult to even to comprehend. A patient stayed for like 61 days. So surgical delays are common. This is what I have. Thank you.
Right, and now, Dr. Kinda.
Thank you, Alexa.
Thank you.
I'm Dr. Patrick Kinder. I'm a orthopedic surgeon and the medical director of the St. John Paul II Orthopedic Mission Hospital in Lusaka, Zambia. I'm actually going to talk in general about what's happening in Zambia in general, because if I want to speak more about my hospital, I'm not going to give you a true picture about what is happening with the trauma epidemic in Zambia. Next slide. Okay, Zambia, it's a small country. It's a landlocked country in the Southern Africa. And it has got about 70 752,614 square kilometers. And it is the ninth largest country in the world. And according to the United Nations, the population in Zambia in 2024, it's about 21 million, 7,000, sorry, of the population. And according to the WHO, it estimates that 2 million of women and men in Zambia live with disability. And we can notice that the major part of this population who live disability comes from a rural area. That's what we're going to see in the next slides, please. And Zambia acknowledged that the trauma is a major cause of disability, either in big cities or in a rural area. But trauma, it's a major cause of disability. And that was a study which was conducted in 2024 for the Plan on Non-Communicable Disease. And there's very little of the national gross domestic product which is allocated to the health expenditure, but most of what is involved, it's actually spent by the patient himself, means come out of the pocket. And in 2020, the total number of disability due to trauma, okay, was 504,000, which resulted in $38 million in economic productivity loss. Next slide. Okay, now the population in Zambia is younger in age, and it grow in size, and trauma become like a greater concern for individual and the national socio-economic well-being. What we want to say by this, that the Zambian population is young, and every year this population is increasing, and it's increased, and that way it was projected that in 2050 the population is going to double, and is going to increase by 5 in 2100. Now, Zambia also, it's one of the country where there's a rapid urbanization. And there are a lot of people coming from out of rural area and living in big cities. And and that is still increasing year by year. And that also increase the high risk of trauma, because as I think the population is too young. Now, what happened, it's in Zambia, we've got actually, when we go to big city, we've got nice roads, okay? And even the way the circulation is regulated, I think is organized. But what happened, it's the population, especially those younger ones, they drink a lot, especially during the weekend and everything, that you find that most of the casualty, most of the trauma comes because of high speeds, and like during the weekend, like the past weekend, we had a long weekend because there was these holidays and everything. Then you find that when you get back on Monday in the hospital, you have got plenty of patients because they drink a lot, they abuse drug, and they drive carelessly. And that's the main cause of trauma in Zambia currently. Next slide. Okay, and Zambia, it's as I said, it's a landlocked country, and the country Zambia actually it's one of the peaceful country in this region, but it's surrounded by some country where there are conflict. And what happened is most of the people from those countries they become refugee here in Zambia. And because of what's happening in those surrounding countries, that because the health system with what is happening, conflict and war, the health system has really collapsed. Now, all those people comes to Zambia, and that is actually impacting of the healthcare system in Zambia, which is now overwhelmed because we've got too many refugee camp here, and known that to give care in the public hospital is free, but those public hospital they don't have enough equipment, even infrastructures. They are not really viable. But when you have many people coming here like that, it just makes things quite difficult. Next slide. Okay, the main cause of trauma in Zambia, there are many causes, but the main cause, the main one is a road traffic accident, and there's wake industrial accident, and where we find mine and construction accident. Those are the type of patient I get on a daily basis in the hospital. There are some like sport injury or people who have been attacked by bandits. Those one they come maybe once in a while, but every day this is a type of trauma we get coming from road traffic, which is the first one, and mine because there are too many mines here in Zambia, and we get more accident from there. Next slide. Okay, this picture, it's showing, actually, this is one of the border. Actually, this is toward the border in between Zambia and the DR Congo. As I was saying, in Zambia, we've got actually city to city, we've got this nice road. But you have these trucks. Now we can see that there's a queue of trucks there, which usually come from South Africa. They have some come Botswana, Namibia, and they have to cross Zambia because the way Zambia is situated, all those countries who actually communicate like with DR Congo and everything, they use Zambia as a passage. And there are many of these trucks in the road, and on top of it, there are also buses with for traveler. And most of our road traffic accidents come from this. That's why recently there was a rule from the government that all the trucks and all those big buses up from 21 hours, that is 9 p.m., they are not supposed to move because people they drive very fast in this road because this is just a border. That's why they have stopped. But when they are in those main roads, they drive fast, and you find these trucks, bus, and they drive the all day. And when you drive the all day like that, you start driving within the all night. Drivers they get tired, and they start dozing when driving, and definitely give this is one of the main cause of trauma in Zambia. Next slide. Okay, apart from those roads, we found some other places like here in some rural area where roads are not very good. And I think I lost actually two of my colleague doctors because they're supposed to go and work in some rural area, but this is a type of road you get there. And for just a short distance, people, you can travel for 1 week or more than that, but just to reach the point you are going. And on top of that, there are too many accidents in such roads. Next slide. Okay, this picture illustrates also generally people who come from a rural area, those are the one actually bring all these because those are the one they've got farmers and everything. Now they bring all this to the city, And that's a way you can see that truck which is behind, even this one where people are falling down, that's a way these trucks are packed. And you see here just that's the lid on that side just open up, then you can see what's happening. And that's what we see every day when all these traders coming from rural area, these trucks, that's where it's packed. And this is also one of the cause of the road traffic accident. Next slide. Okay, then I spoke also about what's happening in the mines. Now, this picture actually, what happened, they are trying to retrieve some illegal mine. Okay, because we have got mine which are well recognized by the country, but we have got also these individual, especially younger ones. They do it's a bit illegal by going to dig some mine and everything without any there's no security, no safeguard about what they are doing. Now here they are trying to retrieve some they were buried in the tunnel which they built to search whatever they were looking for. And now they are trying to find if they can get some who are still alive and everything. And apart from road traffic accidents, most of our patients, even in the well-controlled mines, but we get a lot of trauma from here. Next slide. Okay, this is a type of those illegal mines. That's the way it is. Means they just dig that tunnel and they go there without any protection themselves. They don't have helmet, they don't have safety boots, nothing. And even when they go, is either they find the precious stones they are looking for, or everything can just collapse on them, and that's the end of the story. Next slide. Okay, I spoke also about constructions. Okay, you can see that guy is, I don't know which height is it, but there's nothing to protect him there, just holding with his hand, and no helmets, no belt, and everything. Can you imagine falling from there? Is either he dies directly, or it's most of them with when they fall from these heights, definitely the main one is a spine. They got spine injury, or you can break multiple bones, and that is one of the causes of the trauma in Zambia. Next slide. Okay, the Zambia health system is a decentralized system. Okay, and it's actually offer universal health care, but it faces some challenges. And one of the challenge is the resource scarcity. The Zambian health system is heavily reliant on public funding, which is limited. And that leads first to shortage of manpower, of personnel. And there's a major issue of equipment and supplies. And this is especially in a rural area. On the first or second slide, I was talking about the number of disability is actually high in a rural area, because you have hospital or clinic, but if they get you like an orthopedic surgeon, they post you in those area, you can't work. The only things you can do there is only applying plasters, applying cast, because there's no first even viable operating room, even power, the electricity, it's a problem. And definitely all those patients will get there, you can only put a plaster. And that's actually, when you do that, and all those patients, even when we're talking about shortage of personnel, because in those areas, actually, even to get that orthopedic surgeon is difficult. Okay, most of the work is just done by a general doctor or sometimes by the nurses, and that just complicates things. And the other challenge we have, because if I said, if I want to talk about like my hospital, I will not give a proper picture of what's happening in Zambia, because for us, we don't have that delay in taking patient in the operating room once they get in the hospital. But contrary, in public hospitals, there's this issue of long waiting time and overcrowding. And this leads to patient frustration, stress, but the main one is the impact on the treatment outcome, because you get people with a fractured ankle which is displaced, and but when you're in a public hospital, they even can tell you that we can get you in the operating room after 3 months. And you know what will happening after 3 months, then it's going to have malnutrition and just complicate the better outcome which that patient's supposed to have. And that's one of the main challenge we're having. Next slide. This is just the type of queue as we get in a public hospital. Next slide. Okay, the other challenge, I was talking about the rural area. There's this disparity in to access the care between urban and rural area, with some area lacking of adequate infrastructure and healthcare services. And that is one of the main causes, because even when they train some workers here, especially doctors, surgeons, most of them, they don't like to be posted in the rural area, because first of all, the condition of life are very difficult. And also, when you are posted there, that means you stop actually practicing what you know. And that's give problem. And the population who live in those areas, definitely they are sacrificed, because they can't get good services as someone who is living in a big town can get. Next slide. Okay, this is one of example of one of the hospital in a rural area, and you can see that there's a bush around. And when you go some miles next to this hospital, there are some villages. And such hospital, the first challenge they have is electricity. You can have a fracture there here, and when they take you to the hospital, they are going to have problem that just to do an X-ray. That is going to be a main issue. And they can tell you, no, you have to go to the hospital, which is at 30 kilometers next, and maybe you'll not find even a working X-ray there. And by the time you find X-ray, you have to come back here to show to the doctor. And he doesn't have, even when it's required to do internal fixation, either he doesn't have that skill because he's not qualified for that, or to equipment to reach here, it's also a big challenge. Next slide. This is just one of the example how the take like patient to the hospital in those areas. And when you find the patient, because when you take them there, even the patients, they don't have, especially, okay, that is normal, that do not have that knowledge, this big, they just rely on that person, either is a nurse there, the clinical officer, that whatever they will do, just rely on that one. Then when they come to us, it's maybe 3 months, 6 months later, and sometimes it's just maybe the treatment surgery become difficult. Some they can remain there with an open fracture for many months, and when they have to come to us, you have just to end up with an amputation. Next slide. Okay, the other challenge is a lack of training and the skills drain. Most hospitals don't have orthopedic surgeons, or they don't have qualified anesthetists. This is a problem which you don't find only in rural area, but even in some hospital in big cities. It's a problem to find either you have just a few surgeons, and like in this public hospital, where you don't have enough orthopedic surgeons, but you have a queue of patients, and it's become difficult to attend to all those patients. And equally for anesthetists, I remember there's a time we had also this problem of anesthetists, which were using one anesthetist for 3 hospitals. And what was happening that you are doing your surgery, and they are calling him to the other hospital, and he has given our patient a spine anesthesia. We haven't finished the surgery, but he has to leave us with the patient like that because he need to go to attend to another emergency there. I think that is one of the challenge. Also, there's many trained Zambian surgeons leave the country, or they prefer to work in a private sector. And this is one of the cause of those queue we have in public sectors, because what happened is the surgeons who work for the government, it's there's that issue first of commitment, because either you perform 1 surgery or you perform 10 surgery, your salary will not change. You get the same salary but a month end. Okay, but and when they go in the private, they get paid per case. That's why even though they have been employed by the government, but some they spend the time in the private sectors where they are doing some surgeries, and but when you are talking about private sector, it's just a few people who can access. They can access the care in those hospitals, because they are expensive. The majority of population then go in public hospital, but you go in a public hospital where you don't find doctors, and you don't find skilled surgeons, and that's become difficult. That's why you see they have to operate on you after 3 months, after 6 months. Okay, and that's it's going to impact in the outcome of the treatment. Next slide. The other challenge is the financial barrier. Because here, as I said, basic services are offered free or at a cost-sharing basis in some public institution. But for some specialized procedure, you can't access, because for those one, either they don't have the material, they don't have the equipment, or it become expensive. But people are used to go in those hospitals, they are poor. Now, if you ask, you have to do a CT scan, you have to do an MRI scan, which are expensive tests, then some they will never access to those ones. And those are some of the complications we have. Next slide. Okay, in conclusion, what can say that there's really needs to have good infrastructures and to have orthopedic equipment. We have all these public hospital, government hospital. You can they are big hospital. They receive the majority of patient in Zambia and in Lusaka, but most of them, because what I do like on a daily basis as at my hospital, my phones, those are my phone numbers. They are the one on the website on the hospital. I've got a lot of text in my phone, and some they call every day just to find out how they can come to our hospital to access our care. And it's even difficult to respond to everyone, because they know, it's well known that when you come to my institution, straight away, you will make it to the surgery if you need to have surgery, or they are going to attend to you. But as I said, there's a issue of to have that capability. It's money, it's expensive, it's not free. And that's become a challenge. means we need to have good infrastructure in public and orthopedic equipment. And the other is to have people who are trained. That also, it's one of the big challenge. I was saying that most of the orthopedic surgeons, you just find them in big cities. When you go in the small one, they will tell you that the surgeon will come after 3 months. Now, all those patients with trauma, you have to wait for 3 months for him to come. And that 3 months can be 5 months, 6 months. And you find them, they come to us a little bit late. And when they become late, there are too many complications. And need also of patients to have that ability to access the trauma services. I think someone in that far end remote area, he has to be able to access the same service like someone who is in the big city. I think that's why they are training all these surgeons we have here. But they will train them, but definitely they will not go there because once you send them there, they can't practice. And it's become difficult for people to access to those good services. And the last one is need of monetary resource to support the needs of local system. I think doing that, I know it's a big challenge, but doing this, I think everyone has the rights to have the same type of care wherever you are in the big city or you are in a remote area. Thank you very much.
Thank you, Dr. Kinda. And now Timon will talk to us about orthopedics in Uganda.
Good afternoon. My name is Timon Mark Serwaji, and I was previously a medical student and I've graduated through medical school. I'm now an MD, and I'll be talking about orthopedics in Uganda. Next slide, please. Thank you. Yeah, so Uganda's population is estimated to be 51 million and 384,894 as of 2025. The country has a population density of 257 people per square kilometer, and Uganda covers a total area of 241,555 square kilometers with 204,540 square kilometers being land and 37,013 square kilometers consisting of open water bodies. Next slide. Yeah, so this is the health structure of Uganda. It was squeezed in one slide, but I'll try to explain. So in Uganda, we have a hierarchy where we begin with the health system and components where we have both the public sector and the private medical practice. Under the private medical practice, we have the private health providers. Those are investors that come from other countries and come and build hospitals here for commercial business. And there we have private non-for-profit. Now these are non-government organizations that come and give healthcare, like USAID, where they come and give healthcare for free. And then traditional and complementary medicine practitioners. So these are people that are deep in the villages that offer medicine, and they are not authorized by the government, but in some way they are like traditional healers, and that's how they offer their medicine. Back to the public sector, we have the health services under armed forces and then the local government. Then we move to the government health. This is where the core point is. We have a national referral hospital. Now that is at the bigger level, which we have one in, and that is stationed in Kampala, which is the capital city of Uganda. Then we have 14 regional referral hospitals stationed around Uganda, in different areas of Uganda. And then we have general hospitals, health care or health centers from level 4, level 3, level 2 to village health team. But this is the structure on which ideally they wanted to the system of the healthcare in Uganda to look like. Can we move to the next slide? Yeah, so causes of orthopedic trauma in Uganda, these are some of them. There are quite as many, but these are some of them, and this is what we are going to be concentrating much more in this presentation. The high burden of injuries. And much of these injuries occur due to road traffic injuries and to falls like construction, like hiking, things like that. And now what brings up the overwhelming orthopedic cases is also the limited emergency responses. One of the issues here in Uganda, we do not have even ambulances to take people to the hospital. So most of people die and bleed, like bleed and die after getting accidents, and they do not have hope wherever they get the accidents. Very many people end up losing their lives. And then we have economic burden. As we know, it is really hard for a person to move from a rural area or within even an urban area to go to the hospital, where he's expected to pay for the gloves that he's going to use while he's in the hospital, expected to buy the medicine, and also to be able to pay the surgeon and also for the implants and all that. So with that economic burden, people end up not going to the hospitals, and then we end up with disabilities causing so many consequences following orthopedic trauma. Then we have inadequate health services. Under inadequate health services, here we find that we have limited surgeons in Uganda. And being that we have limited surgeons, so people who are medical doctors, clinical officers, even nurse practitioners, they're able to handle these orthopedic cases when they come to the hospital. Even medical students have to handle these cases because the patient has no option, and if you do not help the patient, there is no way the patient is going to get okay. And one of the last issues here is the poor political system. Well, by this, I mean, in Uganda, people that are rich or people that are in politics, political leaders, when they get sick, they fly to other countries, Asia, Europe, United States. Then the people that are not rich or do not have the money to get medical care, they end up losing their lives. And people do not care. Like, people keep on promising, but nothing happens. And also with the poor political system, you'll find that the good roads are moving to certain places. Like, for example, in Uganda, we do not have an airport. The airport no longer belongs to the people. It was sold to an investor that came in Uganda. So you have to pay to go to the airport. We have one of the best roads, which years ago was estimated to be one of the expensive roads in the entire world. But when you look at the road, a lot of money was embezzled, and that road passes besides the capital city, connecting from where the mines and other goods are coming from straight to the airport. That is one of the things we have. So with a poor political system, you find that it is also contributing to the trauma and also the consequences of trauma that are happening in Uganda. Next slide. Yeah, so this is one of the, I could call it a trading center, and you can see the commotion. The motorcycles you see here, that is the normal public, like, transportation from one place to another. But as you can see, there are no traffic lights. There is no person to direct who. We can say a man carrying boxes. Trauma can happen at any moment. People crossing, people moving, and within such a scenario, I happen to have, one of my sisters who got broken tibia and fibula 2 years ago, and medical care was also hard. So such scenarios cause the reasons why trauma and orthopedics and other kinds of trauma that happens to the people, and then they end up losing their lives. But they have to move in such a scenario because there is nothing to do. Because when you start home, you will not get what to eat and you will die of hunger. We have people with severe malnutrition here in Uganda. Next slide. The same applies here. You can see the commotion. Everyone is taking their directions. People keep on hitting each other every single day. That is the order of the day. And this is a junction without traffic lights. Nobody cares. People are trying to survive, to earn a living. Many of these people actually, they have even lost hope because they are living on a day-to-day life and they don't know what is going to happen tomorrow. And most of them are like, I will live until when I die. That is what is left for them. And that is the normal situation. Next slide. Yeah, so these are, as you can see, these are 4 pictures in one slide. And that is how, now this is the capital city. And you can imagine when it rains, it becomes floods. That means that when it's not raining, we have big potholes in the roads. As you are moving, cars are bouncing on either directions. Cars are falling into trenches. Borders, which are the motorcycles, are also doing the same things. Because if you can just picture, in the rain season, there are floods due to the poor infrastructures. And now, as I was speaking about the road traffic accidents, in the picture, which is at the right upper corner, where we are seeing a policeman, that is a traffic officer, and the car severely damaged. You can imagine whether people that were in that car really survived when the wheels are in the shield. The next slide. Same applies to the same situation. Everyone is going their direction. And these are the, this is not the capital city. These are one of the trading centers. I could call them trading centers because in Uganda we have districts and every district has different trading centers. And with our population and the country, the size of the country, you imagine that you see this quite a lot. Next slide. Now, this is a picture showing one of the orthopedic hospitals here in Uganda. Since we do not have orthopedic surgeons in high numbers, so in some hospitals, people, however much, trauma is one of the leading cause of death, actually, when you combine even the diseases like HIV, diseases like malaria, but still there has been neglect of infrastructure. A person is sick and they are in such an environment, but this is the best that we do have because the caretakers of these patients end up sleeping down due to inadequate beds. And we also improvise by using other beds. We do not have orthopedic beds. And this is what happens. Next slide. As you can see, the commotion in the hospital, patient here, patient there, patient the other side. And now, this is when the room where post-op patients were supposed to be, but inside the room, it was overcrowded and we had to bring them under the shade. That's how overcrowded hospitals are. Next slide. Now you see the mother and the baby are sleeping down, but they have another child that got an accident and is on the bed, but there is nowhere they can sleep. And this is daytime. When it is nighttime, all this floor is overcrowded. People are sleeping under the beds. People are sleep. You cannot even pass anywhere. Next slide. Now, this is right now, I'm at Jinja Regional Referral Hospital, one of the 14 regional referrals here in Uganda, and this is our operating room. We only have 2 lights that can enable the surgeon to see whatsoever they're operating. The one that is there on a stand, but the one that is there on a stand, it is non-functioning. It is faulty, so it does not work. On the top, if you can see on the floor, there is light there. So it is one bulb that is focusing down, and that's all we have. And in front of it, we have an anesthesia machine. So around 2 weeks ago, when we were operating on a kid which was around 9 years, electricity went. And when electricity went, all the machines went off. And this was 11 p.m. and the kid ended up dying. And I asked what is really happening, and people were like, such scenarios happen. We do not have a standby generator, and it is for God to help a person's life to stay alive. This is the condition. As with the cylinder, you can see that is the one for oxygen, and also the other machine next to it. In case, when electricity is on, we don't use the cylinder. When the electricity is off, then that's when we try and use the cylinder. And this is our orthopedic bed. We only have one, and as we shall see in front, it's not in a good shape. The table where you see boxes in the corner, where you see some gentlemen seated, that is the nursing station. Everything the nurse needs, all the orthopedics, all maybe things like where the scrub tech will have to put the instruments. Actually, most of the instruments are there. It's just that they are not visible, but that's what we have. So we keep on improvising. Next slide. Yeah, this is the structure of the operating table. That's how it looks like. And where we have the patient to rest their arms, we use wood. We go to the forest and then we get timber and then we improvise because that's what we have. Yeah, next slide. And that is a case also we had around 2 weeks ago. And this is a person that had got a fracture, but you can see this is a case where we have draped. Remember, we have seen the table, how it bees on a normal day without any operation going on. But now this is an operation going on. And this is how and this is actually our best, because at times the green cloth that we have, they go out when we do not have the sterilization machine, when it does not work, because every cloth that you see on that picture, after the operation, we wash it and then we put it in a sterilizing machine and then we reuse it again. And we used to put certain equipment on the patient's foot when I was still in Kansas, as I was doing their medical rotations. But here we put a glove, a hand glove at the bottom of the foot, so that we can be able to drape that area. And that's how the situation is. And in Uganda, we don't have scrub techs. So as the person that's going to assist the surgeon, you have to be the same person to send the instruments to the surgeon. Next slide. So this is one of the patients. Actually, this patient was like, I'm tired of the hospital. The prices are really so high. I want to go back home. I want to go and get traditional healers, but we are going to see complications that people get when they go and meet traditional healers. These are people that were born and they think that they can fix bones without going to the school to learn anything about the bones. Next slide. Yeah, so major complications and consequences in many orthopedic cases. Fracture-related infections. You just saw the theater. If the theater is like this, that means in the post-operative room, it is way worse. We shall also receive non-unions and mal-unions. Reason being that very many people opt not to come to the hospital. One, implants are very expensive. There are no orthopedic doctors. And also the conditions there are really horrible. And people do not have even money, even if they make it to the hospitals. So they opt calling friends and they're like, can you help me try and massage my foot? Maybe the bone will heal by itself. Most of them come to the hospitals when they are in severe states. And all what we can do is amputations. Some come with very huge infections. They have gone to the pharmacies and they have bought drugs and they have got resistance to very many antibiotics, because you just walk to the pharmacy and you just buy antibiotics. So they are antibiotic resistant, and then we cannot do anything. We try what we can, and most of these cases, people end up losing their lives. Osteomyelitis, infections, joint stiffness. So many of these are the consequences and the complications that very many people with orthopedic cases experience. Depression is a major, major issue. Very many people that end up with accidents months after their accidents, falls, or any orthopedic injuries end up committing suicide because there are no help in the hospitals. The hospitals are focusing on diseases that they can, that they can treat. In Uganda, we have only 10 MRIs, and we have 27 CT scans. But most of the MRIs and the CT scans, they are non-functioning. In the entire Western region where I am right now, we do not have an MRI, we do not have a CT scan. All what we have is an X-ray. And what happens is they operate on you, and then you go for an X-ray, and then the surgeon sees whether they did something that is good for the patient. Other than that, very many patients, we pray that they get healed and they can try and get as much mobility as they can. Things like the physiotherapy, that is not a thing here. You were operated, that is a chance. The lack of review, because surgeons they have a high workload. So they do not have that time to come and review this one. They review those that they can, but the follow-up is really challenging and hard for them, being that patients are coming from very, very far to come and access health services. And the surgeons have to work in multiple hospitals so that they can see that they can help as many as they can. So very many people end up with having suicide, and they die. Next slide. So these are some of the things that we need in Uganda. Orthopedic training. People have limited knowledge about orthopedics. And orthopedics is one of the leading trauma is one of the leading causes of death. And most of the accidents, you'll find trauma from the head to toe. And it is very hard to get in a trauma incident, and then you fail to break a bone. And then on top of that, there are even no hospitals. There are no facilities that are there to come and handle these overwhelming situations. So the order of the day is putting people in casts and praying that, everything will go on well. Diagnostic machines. A country that has more than 51 million people having only 10 MRIs that are actually not functioning. We have few functioning, and limited CT scans, and also X-rays. X-ray machines are also a big deal here in Uganda. They are hard to access to. And operating room instruments and machines. Here, when we want to go and operate, a surgeon who moves with his own tools, where they'll have to sterilize and then put them back. And those tools are the ones that will work on very many patients. The drill. If, let's say, the battery runs out of power in the middle of the operation, that is trouble. So things like that, gloves. So in our situation, where patients, even the hospitals cannot provide gloves for the patients, so it becomes really challenging, even in the operating room. And now, orthopedic implants, that is like a dream that we are praying for, that may come and visit Uganda one day. Yeah. Next slide. Thank you for your time. We can now bring change towards the overwhelming orthopedic trauma in Uganda. Thank you so much.
Thank you. Okay. Did it end? Okay, because it's just not showing up for me.
Hey, Patrick, Timon, can you hear me?
Yes, I can hear you.
Yes.
Hey, hey, thank you guys so much. Dr. Kenda, Dr. Beza, Timon, we've all played a part in your education here at the University of Kansas. I cannot tell you how proud all of you made me. I think that was my favorite talk we've done today. It was, what we've done today on so many of our lectures is throw out a lot of numbers and research studies, but you guys provided a really personal twist to this. You live this every day. And it's impressive. It's impressive how you guys handle these challenges that you have to deal with. So I know a lot of people had to head off to lectures, but if anybody had questions for Dr. Beza, Dr. Kenda, or Timon, we have some time to do that. So we'll just open this up for questions from the audience. Those who have to go to class, feel free to go to class. Thank you, everybody, for coming who came and those who participated. Okay. It looks like we don't have any questions right now. And a lot of our students had to head to class. What do we have in the chat?
Thank you for the thoughtful presentation.
Okay. Anything anybody want to say in closing? I know everybody's busy and has to do things. But did anybody want to say anything in closing? Okay. So Bakker is going to be reaching out to you just to add some things up from your guys' presentations or some ads to add some things from your presentation online. Yeah. So I loved this. I just can't tell you guys how much I loved this presentation. It was so good. It was so concise. It just laid everything out. And I saw things I had not seen before. Just really, really impressive. So just great work. Thank you guys so much.
You're welcome. Thank you.